Next case by Dr. Gokul Reddy, an elderly patient with concomitant CAD and valvular heart disease, and who is a surgical candidate.
Good afternoon. Just going to show some case examples. These are not intervention patients. It's basically about the clinical decision making. So the first patient is a lady, 85-year-old, a diabetic of 20 years. She is on medical management because she refused surgery and was diagnosed as severe aortic stenosis 2 years back. Angiogram was done in Jan 2012 in Care Hospital when I was there. It showed a mid-LAD long lesion with 70% occlusion and RCA, total occlusion with CTO. So we gave an option of CABG, but the patient, CABG with AVR, the patient refused because surgeon there gave a risk of around 25%. And they consulted 3 surgeons outside, 2 of them refused. Other surgeon gave a risk of 50%. So she thought when she was 83-year-old, she's better off without surgery. But she was doing okay till last 1.5 years, around class 2, class 3, I would say. And she had pulmonary edema 1 month back, requiring hospitalization elsewhere. And since then, she's in class 3 and was becoming worse day by day. But the ECG was unremarkable compared to the ECG which was taken 2 years back, showing some LVH strain, nothing else. She was treated with careful IV diuretics. The blood pressure was around 100, 110 maximum. The echo gradient for aortic was around 88 to 100. The EF was 60, preserved. Echo showed also a moderate eccentric MR. The PA pressure was 70. So we are not able to give any nitrates, nor decnidil, nor ranolazine, nor ivabrat. And she was having angina and heart failure. And none of her medication would work. She was orthopneic, always sitting on a bed. We consulted a surgeon. He gave the Euro score was 34.5%. This is the echo, which shows a Vmax of 4.6. This is not playing actually. So the options were multivessel PCI to LAD plus a balloon IT valvotomy because TAV is not yet approved and not available. Second was CABG with AVR. Third was only PTCA2 and medical management of aortic stenosis because the predominant symptoms what we thought were contributed by the coronary also. And fourth was the medical management. But the patient was very keen on having some procedure because her life was miserable since past 3 weeks almost. If I request the chair, what would be the best suggestions possible for this lady?
What is the option for MR? Do you think it is ischemic MR? Severe MR?
It's because of the afterload. The afterload mismatch, the high pressure in the LVOT, in the LV is causing leaking of the MR. Otherwise, pathologically, but for the mitral calcium, nothing else is there in MR.
So there is no mitral valve disease at all?
No mitral disease.
Is the LV dilated?
LV is normal, with the LVH, only LVH.
But normal LV with intact mitral valve, such a severe MR is usually unlikely.
Probably it's an acute MR only, not a chronic
that's
MR.
That's the reason, that's what I'm asking.
Yes.
Acute MR, ischemic MR, that's what I'm asking.
Ischemia is contributing to
ischemic MR, try to contribute because AS MR is a very deadly combination.
Yes, that's true, sir.
So try to take care of the ischemia at least, and so on revascularize because she is not agreeing for the surgery is the first option, as because of severe aortic stenosis. So, but in the absence of patient's willingness for the surgery and wants to undergo, first should think of relief of her ischemic, so that MR gets controlled, then you can go for PBAV in another setting.
Sure. We actually tried our best to control the symptoms of medical management. We could ultimately succeed. Patient was like class 2, class 3, in fact, when we sent for surgery. She had CABG with AVR, she had a long hospital stay, had an acute kidney injury post-op, but recovered just short of hemodialysis. And basically want to highlight that this patient required a multidisciplinary, very, very close follow-up for management. And 6 weeks post-op, she's asymptomatic in class 1, class 2, and she's extremely grateful to have surgery done. The second lady is a 55-year-old from Uzbekistan, had an open mitral valvotomy in 2000 in Russia, came for MVR for mitral restenosis. A routine pre-op angio was done. She has a normal coronaries, but the interesting feature what we noticed, she's actually class 3 again, not moving much. We could not go to the femoral route because of the obstruction at the aortic level. We took a shoot from the radial. What we noticed was occlusion of the aortoiliac junction. The history is not forthcoming. She never had any leg pain, never had any back pain, but was very, very limited in her lifestyle, so probably never exerted too much to have pain. So we actually reviewed the literature about what is the next best strategy. The options were MVR with an iliofemoral bypass in one sitting versus MVR with a staged iliofemoral bypass. In entire Google, we couldn't find a case where MVR was done with a single sitting iliofemoral bypass. So logically, and our surgeon said that MVR involves a lot of risk for infective endocarditis. Hence, we staged the patient and we did an MVR, and she is due for iliofemoral bypass after 6 weeks. And this is the patient most interesting. It's a 55-year-old diabetic patient, had an anterior MI, bypass in 2000 with Lima to LAD and relaterated to the OM, had inferior MI in December 2008. Angioplasty was done to RCA with 2 bare metal stents. Again had angina in March 2009, TMT was positive. Angioplasty was done to RCA with 2 stents, Cypher, and also the angioplasty was done to the Lima with Cypher. Anastomotic site basically. I think files are not playing. Yeah, this is the most recent angio. He is again symptomatic since past 3 months with class 3 angina. This shows a occluded LAD. This shows an occluded stent to the RCA. The 2 ciphers were inside. Actually, first 2 bare metals were there. Then they were done with the 2 ciphers. The 2 ciphers are again occluded. And now is RC total occlusion. This is the only graft which is functioning. The radial artery to the OM. And the Lima to LAD, the stent has occluded again. The stent you are seeing in the distal portion, this has occluded, is a cipher again, it's occluded. So patient actually, since past 3 months in class 3, he has quit his job actually, because not able to go ahead. So what would be the best possible options for this patient? It's to the audience in the chair. He is actually on beta blockers, calcium blockers, ivabradine, ranolazine, nitrates, and still class 3 angina disabling. EF is on 45%, 40-45%, still preserved.
He is willing for redo surgery? He is willing for redo surgery?
Yeah, he is willing for anything because...
So what are the concerns of the surgeon? I think redo surgery is the better. Otherwise, the option is do with the drug-eluting balloon again PCA, staged procedure.
Staged. But actually the Lima, the LAD is not seen at all. When you go back to the angiogram, the LED is hardly seen. I don't know. The LED actually is not able to see. Even it's not being filled.
CT angio, did you demonstrate what is the lumen? In case if you are not able to see the routine angio, sometimes you can see the CT angio, see the lumen. Distal LED is graftability, you can assess.
Yeah, we actually, the RCA was tried elsewhere, but RCA couldn't be done.
Okay.
The next option available to us was whether to do a Ramus PTCA and a Lima to LED PTCA. But we did a viability actually, just to see how much viable it is, because he had an old inferior, old anterior. So it was a surprise, the entire meconium was viable. There was hardly any scar in the, God, it's not playing at all. When you see only the, I'm sorry for the slides, all be messed up. Only the small area of the apex and small area of the mid and distal septum had a scar. None of the LV scar. So after initially actually was planned for a RC PTCA, Ramus PTC and the Lima to LED instant angioplasty, but he's sent for surgery next week. He's due for surgery next week. I think that was the most logical decision. I think you also concur with
Yeah,
it.
exactly. Because there significant angina is there, so definitely full revascularization is preferable rather than going for PCM in one particular vessel.
But the problem is LED is not visible. CT also was done. There
Okay,
also, but the
gotcha.
stent is visible, LED is not visible.
Okay.
So probably the diagonal which is being seen, the Lima is already done. He says we cannot take back the Lima.
Exactly. You
So
can-
probably another
Right.
graft from the vein would be given
Or
to the
vein
diagonal.
big, venous graft should be equally good because
It's true. Thank you.
I think that is the best thing to do.